All right. Hi, good afternoon, everyone, and thank you for joining us. We're going to make a start. My name is Steve Terra, and I'm an executive director of global product development at Pfizer. And Pfizer is actually very pleased to be sponsoring this special virtual education series titled LipidPALOOZA and hosted by the National Lipid Association in celebration of National Cholesterol Education Month. I'm pleased to be joined this afternoon by Dr. Pam Taub, who is the founding director of the STEP Family Cardiac Rehabilitation and Wellness Center, and also an associate professor of medicine at UC San Diego Health System. This afternoon, we'll be discussing advancements in the management of type 2 diabetes, hypertriglyceridemia, and fatty liver disease. Now, we want to take your questions, and you can send them in to us using the Q&A section on the right-hand side of your screen. And during the allotted time, we'll get through as many questions as possible. So I'm now pleased to welcome to the virtual stage Dr. Taub for her presentation.
Thank you. It's great to be here today, and I'm going to be talking to you about three interconnected diseases, and that's type 2 diabetes, hypertriglyceridemia, and non-alcoholic fatty liver disease, or NAFLD. And I'm going to be reviewing with you some of the advances in management of these conditions. These are my disclosures. I'm going to start by giving you an overview of the common pathophysiology that links type 2 diabetes, hypertriglyceridemia, and NAFLD, which we often don't recognize. And then I will delve into some of the novel agents for the treatment of type 2 diabetes that address cardiovascular risk, and that's the SGLT2 inhibitor class and the GLP-1 receptor agonists. Then I will review some of the data surrounding icosapent ethyl, which is a novel agent for the treatment of hypertriglyceridemia. And then I'll end by reviewing NAFLD, including potential treatment options for NAFLD. So there are many factors that contribute to increased risk for atherosclerotic cardiovascular disease. Diabetes is a cardiovascular disease, and the pathophysiology of diabetes involves hyperglycemia and advanced glycation end products leading to increased inflammation, dyslipidemia, including elevated triglycerides, endothelial dysfunction, hypercoagulability, and all of these factors are drivers of atherosclerotic cardiovascular disease. We've learned that just focusing on A1C lowering is not enough, and that when we treat diabetes, we have to use medications that lower cardiovascular risk. Diabetes also is a disease that highlights the intricate links between multiple organ systems, as patients with diabetes have renal and cardiac dysfunction in addition to their endocrine abnormalities. And NAFLD is one manifestation of the adverse effects of cardiometabolic disease that patients with metabolic syndrome and diabetes have. Here is an overview of the different agents that we use to treat type 2 diabetes. The new players are the SGLT2 inhibitors and the GLP-1 agonists. If you contrast these agents with some of the older agents, such as the DPP4s, the glitazones, and the sulfonylurea, what you see is these two classes of drugs have cardiovascular benefit. They also result in weight loss, and the incidence of hypoglycemia is very low. We also have metformin, which is really the standard of care that we use when we are starting any newly diagnosed diabetic, because this is a drug that has been around for a long time. However, in terms of the CV benefit, it really comes from a sub-study of the UK PDS study, and it's not a large clinical trial, but we still lean on metformin as our first agent based on the guideline. But when you look at the SGLT2 inhibitor class and the GLP-1 receptor agonist, you see that they have incredible cardiac benefit as well as renal benefit. And now we're also seeing with the SGLT2 inhibitor class there is also benefit for patients with heart failure. So based on this data, the American Diabetes Association and the American College of Cardiology in the guidelines really call for the use of SGLT2 inhibitors and GLP-1 agonists after metformin. Here is a list of some of the ongoing and completed outcome trials looking at cardiovascular outcomes. As you can see, there have been many trials done, and I'm going to highlight some of the ones that have been positive and also compare the trials between the different classes. So you see the synergy that is there between the SGLT2 receptor class and the GLP-1 receptor agonist. So the first trial that was released was the EMPA-REG outcome trial in 2015. And this was a really impressive trial because it changed the paradigm by which we approach the management of type 2 diabetes. Prior to this trial, we were really focusing on A1C lowering, but this trial showed us that you can use a drug for treatment of patients with type 2 diabetes that can also have cardiovascular benefit. And this was a trial of over 7,000 patients, and what was very surprising was the impact that this drug had on cardiovascular death, with a 38% relative risk reduction and a 2.2 absolute risk reduction in cardiovascular death. Even more amazing is if you closely look at these curves, they start to diverge very quickly. You reach a statistically significant separation of the curves in about 59 days. And another surprising finding from this trial was the benefit in terms of reduction in heart failure hospitalization. So these were very impressive results that started our thinking of diabetes in a different way and really thinking about diabetes more as a cardiovascular disease. This was subsequently followed by the CANVAS trial, which was a cardiovascular outcome trial looking at canagliflozin in 10,142 adults who had type 2 diabetes and established cardiovascular disease. That was about 2/3 of the CANVAS population, and 1/3 of the population had multiple CV risk factors. In the CANVAS trial, there was a 14% relative risk reduction in the 3-point MACE, but there was no changes in the components of the 3-point MACE. One big difference between the CANVAS trial and the EMPA-REG outcome trial is in the EMPA-REG outcome trial, all of the patients had established atherosclerotic cardiovascular disease, while in this trial, only 2/3 of the patient had established ASCVD. The next trial that I'm going to talk about is DECLARE-TIMI with dapagliflozin, and this was also a large trial of over 17,000 patients. And this trial did not achieve its primary endpoint, but what this trial did show is that there was a lower rate of hospitalization for heart failure with dapagliflozin. And this then led to the DAPA heart failure study, which was a landmark study with over 4,600 patients looking at the impact of dapagliflozin for heart failure outcomes in both patients with type 2 diabetes and patients without type 2 diabetes. So in many ways, this also changed the paradigm in that we now thought these drugs that were initially approved for patients with type 2 diabetes could also be used in patients that don't have type 2 diabetes. And in this study, we saw a 4.9 absolute risk reduction in the primary outcome, which was worsening heart failure and death from a cardiovascular cause. So many people thought these results were too good to be true, and then we recently got the results of the EMPEROR reduced trial with empagliflozin. And in this trial, there was a 5.3 absolute risk reduction in the primary endpoint, which was cardiovascular death or hospitalization for heart failure. So these two studies have really shown that the SGLT2 receptor blocker is very beneficial for patients with heart failure with reduced ejection fraction. The trial with heart failure patients with preserved ejection fraction is ongoing, and we are eagerly awaiting those results. These drugs are now indicated for patients with heart failure with reduced ejection fraction. Dapagliflozin has already got the indication from the FDA, and empagliflozin is going to the FDA to get this additional indication. What's really interesting about this trial is, similar to DAPA-HF, half the patients in this trial did not have diabetes, and the patients were on standard of care therapy. 19% of the patients in this trial were on ARNIs. So what these trials tell us is that on top of standard of care therapy for heart failure with reduced ejection fraction, that there is an additional benefit when these SGLT2 receptor SGLT2 inhibitors are added on. So now let's look at mechanistically what might be happening. There is a lot of theories on how SGLT2 inhibitors exhibit their beneficial effects. And when we look at the collective trials with the SGLT2 inhibitors, we see that they have pleiotropic effects. They lower glucose and hemoglobin A1C. They lead to an osmotic diuresis that's both potassium and magnesium sparing, and that doesn't cause adverse activation of the renin-angiotensin-aldosterone system like our conventional diuretics do. They also lead to lowering of blood pressure and weight. They have a renally protective effect, and that's thought to be due to intraglomerular pressure reduction. And as I just mentioned, they have a benefit in lowering heart failure hospitalizations in heart failure patients who have reduced ejection fraction. So a very pleiotropic class of drugs. We don't know exactly all the mechanisms that are involved, but we have many, many studies that are ongoing to give us further insight into some of these cardioprotective mechanisms. Here is a slide that summarizes the different SGLT2 trials in terms of MACE, CV death, and heart failure hospitalizations. And what you see is all of the SGLT2 inhibitors seem to have an impact on heart failure. When you look at CV death, empagliflozin is the one that has the most significant impact. And as I mentioned earlier, Canvas did meet the primary endpoint, which was a composite of non-fatal MI, non-fatal stroke, and CV death. So you can look at these SGLT2 inhibitors as having a class effect in terms of heart failure, but a differential effect in terms of CV death, with empagliflozin having the most significant reduction in CV death. So now let me switch to another class of drugs, which are the GLP-1 receptor agonists. And they act on the incretin system, which has been an important target in the treatment of type 2 diabetes. And they're an incredible class of drugs as well, in that they also have pleiotropic effects. Stimulation of the GLP-1 receptor causes a decrease in gastric emptying, a decrease in appetite, and this is responsible for the significant weight loss that you get with this class of drugs. They also result in insulin secretion, and they have both cardioprotective effects and neuroprotective effects. So a lot of different cardioprotective and neuroprotective effects with this drug class as well. We'll compare and contrast the SGLT2s and the GLP-1s, because when you look at some of the mechanisms side by side, you'll see that they're actually very synergistic. The trial that was done to show the benefit of the GLP-1 receptor class that was initially released was the LEADER study. And this was a study of over 9,000 patients who were either randomized to liraglutide or standard of care plus a placebo. And what you see here in the LEADER study is that it did meet its primary endpoint, which was a reduction in CV death, non-fatal MI, or non-fatal stroke in the liraglutide group. I juxtapose both the EMPA-REG outcome and the LEADER study next to each other just to demonstrate that there is the synergy between these two groups of drugs. So in the LEADER study, what you see is the curves start to separate really after about 9 months. And this is very similar to what we see in lipid-lowering drugs. So when we see this type of curve, it's usually an effect on the atherosclerotic plaque. It takes time to work, and then you start to see the benefits. Versus in the EMPA-REG outcome trial, you see a very early separation of the curves. In as little as 59 days, these curves start to separate. And this really argues for another type of mechanism, a hemodynamic mechanism. And we see that in all of the data with the heart failure patients. And so these are very synergistic classes of drugs that have different mechanisms, but when you use them together in many patients, you have a synergistic effect. The most recent trial was the SUSTAIN program that looked at semaglutide. And in the SUSTAIN program, what they saw, which was very interesting, is it met its primary outcome, but there was an effect on non-fatal stroke. So with the SGLT2 inhibitor class, we haven't seen an effect on stroke. So this again speaks to that neuroprotective mechanism that I talked about earlier. We now have an oral formulation of semaglutide. So let's review the indications for these classes of drugs that the FDA has given, and these indications are going to be increasing based on some of the recent trial results. So when you look at empagliflozin, the FDA indication is reduction of CV death. Canagliflozin is for reduction of adverse CV events, and based on another trial, which I haven't mentioned, the Credence trial, it also has an indication for renal protection. Dapagliflozin, based on DECLARE-TIMI and DAPA-HF, has a heart failure indication. Liraglutide has an indication for reduction of adverse CV events, and so does semaglutide. So these are just the current indications, and it will be really interesting to see all of the new indications that evolve for these drugs. Here I've juxtaposed again the SGLT2 inhibitors and the GLP-1 receptor agonists just to demonstrate the different mechanisms that they're working on. So what you see most prominently with the EMPA-REG outcome trial is the reduction in the CV death and the heart failure hospitalization. It's much more pronounced with empagliflozin than with liraglutide or semaglutide in LEADER and SUSTAIN-6. But then when you look at reduction in stroke, SUSTAIN-6 really shines compared to the data from EMPA-REG and LEADER. So you can see why I talk about the GLP-1 receptor agonist as really having more of an effect on that atherosclerotic plaque, and the SGLT2 inhibitors having more of that hemodynamic impact. So as I mentioned earlier, the ADA and the ACC have really highlighted these two classes of drugs in the guidelines after metformin and lifestyle therapy. And so for patients who have a heart failure indication or are very high risk for heart failure, we should really be turning to the SGLT2 receptor class. For patients who've had a stroke or high risk for stroke, if you have to pick which one to start, consider the GLP-1 receptor agonist class. So now I'm going to shift to talking about triglycerides and cardiovascular risk. This has been something that we've been concerned about for many years because we know that elevated triglycerides are associated with increased risk of cardiovascular events. However, a lot of the drugs that we used, such as fibrates, to target triglyceride lowering did not reduce cardiovascular mortality. The recent REDUCE-IT trial was very, very interesting because it was the first trial in which triglycerides were targeted, and there was also an improvement in CV outcomes. What we've learned from the REDUCE-IT trial is that this is also a very pleiotropic drug that does other things, such as lowers levels of inflammation. And in the REDUCE-IT trial, over 8,000 patients were randomized to either a statin plus placebo as therapy or statin plus icosapent ethyl. And what we saw is that there was a 25% relative risk reduction or a 4.8 absolute risk reduction in the composite endpoint, which consisted of CV death, non-fatal MI, non-fatal stroke, unstable angina that required hospitalization, and coronary revascularization. And so very potent results with a number needed to treat of 21. And one of the interesting things about this drug is there's a lot of other impacts that it has, including improving endothelial dysfunction, making the atherosclerotic plaque more stable. And as I mentioned earlier, there's also anti-inflammatory effects. And in the trial, when you stratified groups of patients based on their triglyceride level, you saw that even patients with just moderately elevated triglyceride levels in the 150s benefited from this drug. So now let me talk about NAFLD. And this is something that everyone needs to be more familiar with. We used to think about this as a disease condition that only gastroenterologists or liver specialists needed to know about. But this is a condition that is very common. In the US, about 24% of patients have NAFLD. And what most people don't realize is these patients with NAFLD are not dying from liver disease or like hepatocellular carcinoma, but it's actually the cardiovascular disease that's killing these patients. So there's a spectrum when you talk about NAFLD. So NAFLD is a less dangerous version of NASH. So NASH refers to non-alcoholic steatohepatitis, and from a histological perspective, it's associated with inflammation and fibrosis, and this condition often leads to cirrhosis and liver cancer. NAFLD is less dangerous because it's where you can actually intervene and reverse the condition, and especially with strategies like lifestyle modification. And again, we have to remember in both patients with NAFLD and NASH, cardiovascular disease is the leading cause of death. Here is a good summary of how NAFLD increases the risk of cardiovascular disease. This reiterates a lot of the mechanisms that I was talking about earlier, the endothelial dysfunction, oxidative stress, plaque instability, inflammation. All of these mechanisms are at play in NAFLD just as they are in patients who have type 2 diabetes and in patients with atherosclerotic cardiovascular disease. Currently, there are no FDA-approved treatments for NAFLD or NASH, but there's a lot of things we can still do for these patients. One of the most important things we can do, especially when we recognize that they have NAFLD, is to start lifestyle strategies. And it does work, and I'll show you some examples of how lifestyle strategies do work. If these patients have diabetes, you can think about a GLP-1 receptor agonist, because there was a small trial called the LEAN trial of about 52 patients in which liraglutide was administered to patients with NASH, and what they saw is histological resolution of NASH. But again, a small study. There's also some data that SGLT2 inhibitors might have benefit in patients with NAFLD and NASH. Other things to consider in these patients is just general cardiovascular risk factor management. That includes their dyslipidemia, their hypertension, if they have significant obesity, really addressing that issue. So here is a patient of mine who had NAFLD that was initially detected by ultrasound, and subsequently, because he was part of a research study that I'm conducting, we were able to get an MRI with a proton density fat fraction. So this is a non-invasive way of assessing liver fat. And before he started our study, his liver fat percentage was 14.4%. And so this was a patient that enrolled in one of our studies on time-restricted eating, which is a lifestyle strategy in which we ask patients to pick 10 hours during the day that they want to eat, and they fast for 14 hours. This resulted in significant weight loss and also improvement of his lipid parameters, but we also saw on MRI a regression in the liver fat. So lifestyle changes can work in these patients. So in conclusion, type 2 diabetes, hypertriglyceridemia, and NASH and NAFLD really comprise the spectrum of cardiometabolic disease. They all have overlapping risk factors and increase the risk of cardiovascular mortality. We can't forget that lifestyle interventions really are the cornerstone in our approach to treating these conditions. And there are a lot of very promising pharmacotherapies that really synergize with these lifestyle interventions. Thank you for your time, and I look forward to taking your questions.
Super. Thank you, Dr. Taub. So in the next just couple of minutes, I just want to talk about first starting off with Pfizer's strategy in internal medicine. And really our focus in internal medicine is centered around metabolism, which is rather appropriate and germane given the prior sort of talk. But what we are really sort of focused on is how the dysmetabolic state is a major pathophysiological driver to the disease areas that we are working in. And those are NASH, type 2 diabetes, and obesity, and cardiovascular disease. And what I'd like to do today is actually spend a few minutes specifically talking about vupanorsen, which is a medicine that we have in development for dyslipidemia and cardiovascular disease. So vupanorsen is an antisense oligonucleotide which targets angiopoietin-like 3 or ANGPTL3. And ANGPTL3 is secreted from the liver and has really emerged as a key regulator of lipid metabolism. So the top half of this figure shows sort of the homeostatic role of ANGPTL3, and you can see that it inhibits lipoprotein lipase or LPL, as well as inhibiting endothelial lipase or EL. And as a result, ANGPTL3 is a key regulator not only of VLDL and triglycerides, but also actually LDL cholesterol levels as well. Now, the bottom half of the figure sort of depicts what happens pharmacologically by inhibiting angiopoietin-like 3, such as using vupanorsen. And what you can see is you sort of have now an increase in the activity of lipoprotein lipase and an increase in the activity of endothelial lipase. And as a result, you see marked reductions in VLDL and triglycerides, but also reductions in LDL as well, which are independent from the classic LDL receptor pathway. And so as you think about ways to potentially reduce the risk, residual risk that's related to dyslipidemia, this potentially is a promising therapy to do so. The last thing I'll mention on this slide that makes ANGPTL3 an attractive target is that it's genetically validated. So there are humans that have either partial or complete loss of function in ANGPTL3, and they have reduced concentrations of VLDL-C, LDL cholesterol, and ApoB, as you'd expect based on the mechanism that we've outlined. But importantly, when one looks at large observational data sets, individuals who are heterozygous for a loss of function mutation in ANGPTL3, they have a reduced risk of coronary artery disease. So again, I think the biology and the genetic data support pursuing this as a potential way to reduce the residual risk of cardiovascular disease. Shown on this slide are phase 1 results from a study of vupanorsen published in New England Journal of Medicine. And the population here were actually individuals who had elevated triglycerides, but who were otherwise healthy volunteers. And if you focus on the far right, we'll go from sort of right to left here. This looks at the percent change from baseline in fasting triglycerides. And again, this was a small study. This was actually done by our colleagues at Ionis and Axia. This looked at weekly dosing of vupanorsen to attain steady state quicker. But in these relatively healthy populations, you see a maximal reduction in fasting triglycerides of 63%. The middle panel looks at non-HDL cholesterol change from baseline, and you see here a nice dose-dependent reduction. with a maximum reduction from baseline of 37% in non-HDL cholesterol. And then finally on the left, this is not part of our phase 1 study, but what this is actually work led by investigators at the TIMI study group, where they conducted a large meta-analysis of 49 trials, and they looked at the relationship between non-HDL cholesterol reductions and relative risk of major vascular events for several drug classes. And what you can see is a nice relationship between reductions in non-HDL and a reduction in the risk of vascular events. So again, providing confidence for us as we design future trials of buprenorphine to properly design and power a trial for CV risk reduction. So I'm going to end with this slide here, which talks about our soon-to-start phase 2b study for buprenorphine called Translate TIMI 70. We are thrilled to collaborate with the TIMI study group on the design, execution, and leadership of this trial. The overarching objective of this dose-ranging study is to identify an optimally efficacious and safe dose of buprenorphine for phase 3 development. And we'll enroll patients who are statin-treated and have mixed dyslipidemia, defined as a non-HDL greater than or equal to 100, and fasting triglycerides 150 to 500. And we look forward to getting the results of this trial to inform future development. So with that, I'm going to close, and we're going to go to the Q&A, and this session is going to go to 4:10, so we'll have time for your questions, and I'm going to sort of moderate with Dr. Taub's help, and we'll go through the questions here. And so I guess, Dr. Taub, one question for you to start right off the bat is recommendations in treating hypertriglyceridemia, let's say a patient with trigs between 400 to 800 who has diabetes and with NAFLD.
So the first thing that you always want to do with these patients is maximize the statin. So this is a patient that I would get on a high intensity statin, whether it's a atorvastatin 80 or rosuvastatin 40. So that's step one. And remember that statins are also going to give you some triglyceride lowering effect. If the triglycerides are still elevated, then you can add additional agents. Given the benefit of icosapent ethyl in terms of cardiovascular mortality, that would be my next go-to agent. But in terms of the triglyceride lowering, probably going to get 20–30% lowering. There are some people, despite statins and icosapent ethyl, may still have elevated triglycerides over 500. And so those are patients you may have to go to a fibrate to get even additional lowering. So a lot of times you have to use combination therapy in these patients. And of course, you want to focus on lifestyle changes that they make to optimize their triglycerides.
So a couple more questions coming in with respect to NAFLD. Can you touch on the effects of statins, metformin, and pioglitazone on fatty liver?
Well, if you think about the pathophysiology of fatty liver disease, the patients that are susceptible to it are patients who have type 2 diabetes, they have obesity, and insulin resistance. So when you do or employ drugs like metformin or pioglitazone, you're kind of addressing some of this underlying dysfunction that they have. So you can use pioglitazone, but you have to make sure they don't have a history of congestive heart failure. Metformin helps in multiple ways. There's a little bit of weight loss with it, but it addresses the underlying insulin sensitivity and insulin resistant issues that these patients have. So you definitely want to try those agents. Statins are interesting because a lot of people, when they see fatty liver, don't want to start patients on statins because patients who have fatty liver have mild LFT elevations at baseline. So people are scared to start statins and see elevations in LFTs, but lots of studies have shown that statins are actually beneficial in patients with fatty liver. So even if they have minor LFTs, start the statin because there's going to be an overall benefit. And most of the time, you don't see the LFTs go to 3 times the upper limits of normal. It may be just a mild elevation. but statins, metformin, pioglitazone, and now with some of the recent data, GLP-1 receptor agonists and SGLT2s are medications you want to deploy for these patients.
Super, thank you. So again, just as a reminder for the audience, we'll go to 410 with sort of questions, and thanks for sending your questions. Dr. Taub, I had a feeling this one would come up based on sort of the patient you talked about with the MRI results, and that is specifically talking a little bit more about time-restricted eating.
Oh, I love talking about time-restricted eating. So time-restricted eating is a way, it's a lifestyle strategy. It does not call, when you tell someone to do time-restricted eating, you don't tell them how many calories they need to consume, and you really don't give them strict guidelines on what type of diet that they need to be eating. What you tell them is limit the amount of food, limit your caloric intake to a certain period of time. So the studies that I do, we do a strategy of 10 hours of eating and 14 hours of fasting. And the reason we do that is because we find that for long-term adherence, people are able to restrict their caloric intake to 10 hours. And we think that the 14 hours of fasting really rejuvenates the cells. And in a more pathophysiological way, what happens when you fast is your body shifts to producing ketone bodies like beta hydroxybutyrate. And ketone bodies are very beneficial in many ways. They stimulate good pathways. They also are, the myocardium loves ketone bodies. The brain likes ketone bodies. So fasting is really a way to be in a ketogenic state in a very safe way. There's a lot of people that do the ketogenic diet, which is very healthy. It's very high in fat and often leads to increase in lipid levels. And so fasting is a safer way to achieve some of the benefits of the ketogenic diet because you do have weight loss. In our studies, we see a 3 to 5% weight loss when people engage in time-restricted eating, but we also see a lowering of LDL cholesterol, a lowering of blood pressure, and with the patient that I showed you, regression in fatty liver. And what's interesting is it's out of proportion to what you see from just reduced caloric intake and just weight loss. Just pure weight loss from reduced caloric intake doesn't get you all the benefits that fasting or time-restricted eating gives you.
Terrific, terrific. So one question that came up that I will take, just at looking in terms of more details about sort of pipeline and internal medicine, and I'll sort of, cover that. Again, we're really sort of focused on metabolism. And so, in the NASH area, we have several compounds in development, including monotherapies and combination therapies. Again, think back at that slide that Dr. Taub showed about the complex pathophysiology. And so ultimately, like in the treatment of diabetes or hypertension, right, probably combination approaches might be needed. And so we have both sort of single agent and combination approaches for NASH. In the type 2 diabetes space, we have a non-peptide oral GLP-1 agent that is in development, for which we've presented data at this year's ADA with very encouraging A1C and weight loss data. We talked about vupanorsen in detail in terms of cardiovascular disease. Probably the other area just to mention for completeness, not exactly aligned with sort of today's talk, but again around metabolism, is looking at actually cachexia in the various disease states for which patients have cachexia, including, for example, cancer cachexia. So sort of in a broad brush, those are kind of the main approaches that we're currently looking at in the internal medicine space. So maybe time for one more question. And Dr. Taub, again, you talked about REDUCE-IT and the benefits of Vascepa in that trial. Any rationale to combine lower dose of Vascepa with perhaps fenofibrate as opposed to using sort of the higher dose of Vascepa that was used in REDUCE-IT?
I'm a purist when it comes to clinical trials in that you use the dose in the trial. For instance, with our heart failure patients, I mean, our dosing is so low for beta blockers and other agents that are cardioprotective. So I use the dose in the trial because that was the dose that led to the benefit. Of course, if there's patient intolerance issues, sometimes you can instead of doing the 2 grams, you might start with 1 gram, but I really like to do the higher dose because that's where the data is.